I hope you all have enjoyed your meal. We will now begin the second session of our conference, which focuses on technology, health, gender. This session will be chaired by Dr. Hamna. Dr. Hamna is a Senior Research Fellow at CREP and Associate Professor at Lahore School of Economics. Please, Dr. Hamna, lead us through the session.
Thank you so much, Zainab. So I hope all of you are awake after your meals. The first person who will be presenting in this session is Farhina, and she'll be presenting very interesting results on the study that they've done with the Punjab Safe City Authority. So over to you, Farhina.
Good afternoon. So, I'll be presenting my really preliminary work. So, I'm really looking forward to all the comments we can get there. It's a study with the Shehryar Badauri and Jairam Saab, and it's basically about the Women's Safety Act that has been launched here in Pakistan. So, the motivation is that, which I don't think we have to, being South Asian, all of us, that there is a lack of women's presence in the public space, and we do have some restricted mobility if you think about going out for a walk or in a public space or public transport. Two primary reasons that the literature indicates towards is, one is the safety issue, which is harassment and sexual violence incidents that's so high that women and girls are scared to go out, or they avoid routes which they feel are unsafe. And the other is gender norms, where primarily women are associated with working within the households and not going outside for cultural or religious reasons. What I'll be focusing on in our paper is the first one, and seeing if improving on that would help us improve their mobility. So just looking into the literature, there's an upsurge of technological innovations, especially in terms of safety. So in 2012, after the rape case in India, there was a surge of all the interventions, technological-based interventions to make women safe out in public. Similarly, there are in other developing countries in Africa. So review tells us that there are approximately 327 mobile applications just on women's safety and how to reduce the gender-based violence. So, but if you look into their evaluations and the literature, we find that there is some literature that examines the efficacy of the panic buttons and what makes those panic buttons more useful, when is that they are utilized more, what makes them more effective, and similarly, the applications, which are safety-enhancing applications, they are seen with a, say, feminist perspective. So, are they really empowering women? Are they really reducing their gender-based violence or not? So, those are the kind of literature that we see, but not exactly their evaluations in terms of reducing the gender-based violence, or, on the other hand, improving any of the other economic outcomes. So, our primary research question is, what is the impact of this Women's Safety Act that has been launched here in Pakistan on participants' mobility and transportation choices? And here our participants are women. And does this, again, just to explore what are the mechanisms and what's happening here, we explore if these results are depending upon the trusted authority or the mobility agency that women have, and by mobility agency, if they're allowed to go out or not. So we contributed to several literature streams. One of them is the most primary, examining the impact of a safety-enhancing application on women's mobility outcomes. So we do not have a rigorous causal evaluation evaluating how these safety apps affect any of the outcomes. So that's one of the main contributions of this paper. This paper will also be contributing on interventions we know that there are lots of papers on public transportation which examine if female-only transportation can help, or if police patrolling in public spaces would help us or reduce violence, or street lights. So there are causal studies which examine the causal impact of these interventions. There are other interventions too, but they haven't been causally evaluated. The role of trust in authorities in the efficacy of policy intervention. There was again lots of discussion on this because of COVID-19. So what is the relationship between the trust in governments and complying to policies that the government bring forward? Right, so that is again what we'll also be looking into this study. So the app that I'm talking about and we're going to evaluate here was already launched in 2017, far before we even started looking into it. And it was again relaunched, the same product was relaunched, probably the change in governments. Also they said there was a change in ownership because it was primarily a Punjab Safe City Authority's product, and then the Punjab Police also took over in 2020, took the ownership, and they relaunched it. However, when we started this study, they had this huge problem of extremely low take-up rate. Less than 1% of the female population within the province, and we're talking about Punjab, took up. So it was almost not being utilized by the target population. The features that this app had was the primary feature which they were really excited about was the panic button. And so the idea behind the panic button was to reduce the emergency response rate. So if you are in an emergency, you press that, that will send your GPS coordinates to the police, so they do not have to ask you where are you, where do you look, which road, exactly which part, and they get the GPS coordinates, they share with the relevant authorities, and they can exactly get where you are. So that was the most exciting feature that they thought should be helpful. The second is the chat. So if you cannot call them, you can chat with their representatives. And then the last one was they just put in a lot of documents, a lot of information in terms of what are the legal repercussions, what are the legal laws related to women and child abuse or harassment, and what other resources that women can access in terms of if they're in an emergency. So what we did was just taking advantage of the extremely low take-up rate of this app. We partnered with Punjab Safe City Authority and we conducted a field experiment using an RCT with the women aged 18 to 55 years residing in low middle income neighborhoods of Lahore. The idea behind targeting low income neighborhood households was because these are the women who do not own private transportation, and these are the ones who would most often go out on the roads, either they walk or they use public transportation. The inclusion criteria required that the woman has a smartphone to be able to download the application, but also they need to have access to mobile data connection because the first feature of the mobile app, which is sending the GPS coordinates, doesn't work if the data isn't on. So that's why that was the inclusion criteria. We started off with the sample of 692 and then randomly assigned them to control and treatment. So what we did was the intervention was, since the app was already there and it was everybody could access it, our intervention is that we produced a video which was telling what this women's safety app is and how it works, what are the authorities doing at the back end, what are the different situations that women can utilize this app in, right? So it was approximately a 6-minute long video that we used and we showed that to the treatment group. And then as a second part, am I loud enough? Okay. So as a second part, we also facilitated them downloading the app and registering for the app. So if we ask them that are you interested and they say yes, so we just registered them and download the app. For the control, we try to use a similar app, which is again a government-run app, Pakistan Citizen Portal, which was active by then. I'm not sure, I don't didn't show them, but the second step was the same. If they wanted, we downloaded the app for them and got them registered on the app. So the survey was collected from 319, that's after an attrition. The baseline was still 692, but we had huge attrition between the baseline and the intervention. So we believe it's a lot to do with the way we were collecting the data, but generally too, we are not sure. There wasn't a lot, it wasn't a systematic change. Our sample was still random between treatment and control, so, but that's what we faced. Apart from surveys, we also collected GPS data through Google Maps. So what we did was we created an account for each participant, and we added that account to their Google Maps account in addition to what they already had, with their consent, of course. And so that account helped us track their mobility using GPS and get an exact, accurate information on their travel. Through that, we get 30,909 local trips, and when I say local, we have kind of restricted in terms of the time and the distance that they have traveled, kind of removing some of the outliers, which were like more than 500 kilometers in a day or something like that. So the third source of data was travel diaries, which was collected on a monthly basis, and that was done post-intervention. As I said, there was a lot of attrition that was happening, and so just as a kind of a backup, we thought that we must manually look for travel diaries, and so they were doing more or less the same thing. We would call them once in a month and ask them what were their number of trips, where did they go, why did they go, what was their transportation mode in the past 1 week. So individually we asked for every day and then every detail of every trip. So that's what we did, and through that we got information about approximately 2,443 trips. That's the timeline. I hope you can see it. So we have attrition, the biggest attrition after the from baseline to intervention. Then we have midline, some attrition there. We started travel diaries between June, which is approximately the time between the midline and the endline. What I want to highlight here is that this is not a balanced panel. So there are people who dropped out, but there are also people who come in back. Especially with travel diaries, we wouldn't get everybody every time, every month, so they would be up and down, but regardless, we're still using all the data that we have with us. That's the balance table post-attrition, and we see that the sample is balanced, except for this one category, which is owned land, and the treatment group owns more land than the control. So we are using two specifications. One is difference in difference, and that's to examine their mobility, where we want to see what beta looks like with three major dependent variables. One is the number of trips that they're taking per day, the distance per trip per day, and the duration or the time that they're spending on each trip. We have certain control variables, which is age, marital status, trust in the police, mobility agency, and household wealth index, and trip timing, just to see if it's day or night or Ramadan or there are any other such effects. And the other is the transportation choice. Again, from Google mobility data, we do not know what kind of transportation method are they using, but we do get know that through travel diaries. What transportation method are they using, and who are they going out with? So who's their trip company? So for that we use make use of the randomization across treatment and control, since we do not have that at the baseline, and we just run linear regression with two dependent variables. The first is if they are walking as opposed to using a public or a private transportation, and the other is if they are taking the trip unchaperoned as compared to either going with a female companion or a male companion. And there are similar list of controls there. So this is just to show the trends. I'm little of running late on my time, so I just skip those. This is just to show the trends across. Okay, so I'll just skip to the results. the trips, the distance and the duration. As you can see, there is no effect on the total number of trips that the women take. It does not increase the distance that they're traveling, but it does increase the time they're spending on each trip by approximately 7 minutes. So that's huge, and compared to the mean, the average time spent on each trip in the control is approximately 27% increase. Looking the same for the transportation methods and the trip company, we do not see any impact on the people, women going out alone, but we do see that more women are now walking. So they go, instead of using private or public transportation, they're shifting towards walking. As I said, we want to know if it's driven by the trust, and we see that the last three columns, 4, 5, 6, those are the individuals who do not trust the police. We do not see any significance there, which means all the results are being driven only by the portion of the participants who trust the police or who trust the authorities. And for them, the intervention is increasing the duration by approximately 15 minutes per trip, but they are reducing the total number of trips by approximately 1 trip per day. For walking, it's not different. It's not different across the two samples, who trust and who don't trust. But for unchaperoned, the people who trust, they also increase their going out alone on unchaperoned trips by approximately 25 percentage points, which is kind of huge there. This is absolutely exploratory. We are looking for mobility agency, and I'll just quickly say that. So these are women who are. So we asked a question there, asking them if they are allowed to go out alone or with friends and family, and so here the people who are permitted to travel alone are the ones who are going out unchaperoned. So we are not absolutely changing the gender norms or people are allowed. So it's basically the people who are already allowed to go out. Those are the people who are making alone trips more and walking and going out, spending more time. So just to quickly summarize, there's a mistake here. It's an extensive margin. The Women's Safety Act does not increase the female mobility on extensive margin. It does increase on the intensive margin in terms of the duration of time by approximately 27 percentage points. Women shift their transportation choices from private and public transport to walking. And these findings are driven by participants who actually trust the police. However, women who already have the agency to go out alone are the ones who are also increasing their unchaperoned trips and not those who are not allowed to go out. So again, as I said, these are absolutely preliminary findings that we have, and I welcome any comments. Thank you.
Thank you so much, Farina. I would now like to invite Salman to provide his comments.
First of all, it's a very important topic especially for Pakistan, and women empowerment and neighborhood participation, I believe, is the way forward for Pakistan. And I really enjoyed reading this paper. And while I was reading this paper, I could think of many dimensions that can be extended from this paper, and this study could be converted into one comprehensive. So I have a few comments. So first of all, there is some concern about the randomization here, and I would like to show you why. If you see that, as Farina mentioned, one of the indicator owning land is different among treatment and group. In fact, treated group had more land, and that indicator is very important because it's a proxy for rural empowerment, and which is being discussed here. Not only that, if you look at the results, you would see that most of the coefficients of treatment group are statistically significant, which means that to each treatment, the treatment and control groups were different, which raises some concerns about the randomization. And I could see that in everything. So, but it's an easy fix. So first of all, the outcome measure in balance table would pre-treatment would suggest if they are really similar or not. If they are not, then the methodology used, the difference in different method can address the pre-treatment difference. Under some assumption, of course, it wouldn't be the experimental study, then it would be a causal experiment. But if those were the same, but after iteration it's different, then that suggests that there is a systematic inclusion, and we need to discuss that. Regardless, because there is an iteration, I would suggest to use intent to treat as an IV for the analysis. Moving on, there is some concerns about stability treatment value assumptions. So basically, the treatment should not affect the control. And because the study relies on the trust on the government institution, the Citizen Portal app also, you could think of building trust in the masses. So in a way, that app might also affect the control. But again, it's an easy fix. You can test it using trust outcomes if they are different in control group, pre-treatment or anti-treatment. But then this trend made me worried about SCORE more, because if you see, the control group falls significantly after the treatment, and the treated group did not fall significantly, and the difference is the main driver of the results here. So I don't know. Seems like there is something happens around that date that leads to that, which might need further exploration. Then I would like to see the heterogeneous treatment effect based on labor force participation. So in the study, you could see that there is no effect on the number of trips. But if you think about it, if you are a working woman, your trips are kind of fixed. You are going to the office, coming back to the office, and after that there is not much left. There might be some increase in luxury trips, but for women who are already in labor force, it's difficult to capture that. But if you look at the heterogeneous treatment effect of the women who are not in labor force, I believe that you may find some treatment effect there. In addition to that, I have many dimensions that I can think of, and because I'm out of time, so I will discuss it further now later.
Thank you. That's a very interesting study. I was wondering, do you have data on app use itself? Like how, and did you find anything? But then it would still be interesting to hear what are broadly the patterns of that app and what that might tell you something about the mechanisms for change, right? If there's no active engagement with the app in general, what is it? It's just making them feel safer or so on. It would be helpful to get this information.
Dr. Naveed.
You said public-private transport trips go down, and now private transport trips simply mean that a family member is dropping them. So I think that you should separate it. I don't know if you can, but there is a separate issue that the brother or father or somebody is actually dropping them on a motorcycle. So in that sense, if that is the case, then if the trips on true public transport haven't changed, but it is that one, then clearly it has a very interesting impact that will now feel more comfortable walking when the distance is not that far, rather than asking, waiting for, or depending on a relative to drop them.
Yeah, Sonia.
Thank you. Very interesting presentation, Marina. So I have two questions. The first one is, do you have any measures on how attentively were the study participants watching the video through which it would give them information? Because if there is heterogeneity in that, I suppose it would affect the...
Sorry, could you say that again?
How attentive they were in sort of viewing that video, because that could also lead to heterogeneity in the ability to navigate the app later on. And my second question is, during the entire study period, was there ever, what I'm interested in knowing is that were there frequent breakdowns in the app, were there any glitches that may have affected the user's ability to use the app at any point?
Thank you so much. Over to you, Irina.
Thank you so much, Salman, for your comments and questions, everybody. So I agree with the concerns about randomization. There is related to the land, and that's why we kind of control. We also understand that female labor participation would affect the trips that you're taking, the number of trips, or the distance, or the duration. So we have certain controls there in addition to just running the difference and difference to overcome the randomization issue. Attrition, again, as I said, I acknowledge that, but we still haven't done a lot about it. We have to work on that. Heterogeneous effects by labor force participation, I think we should definitely explore that. But I remember our sample, there was only like 17 or 18% of the women who were actually working. So it's really small percentage, but at least on the mobility, since we have large data, we might be able to find something. So yes, that can be done. App utilization, so yes, we got the data, administrative data from Punjab Safe City Authority. Unfortunately, none of them utilized it. So it wasn't like they didn't even send a message or a call or even like a test call saying that, oh, does it work? So nobody did that. So yes, all of this is really coming from just the information that we gave them. Unfortunately, Dunya, coming to your point, we do not measure if they are actually attentive. All we do measure is, did they complete the video or not? So yes, that's what we have, but not in terms of the attention that they were paying. You understand that. Yes.
Did they have to sort of watch that video on their own, or whether
No. So anyway, it is sat with them while they watch. So yeah. So that is what we have data on that. Coming to the point on the public transportation, so we just have that data in terms of the transportation choice on the mobile, the travel diaries, and we can. So there were a lot of trips where they were also taking a mix of transportation choice. So they might walk till the bus stop and then take the bus, right? So we try to, the reason we brought walking in, because you're right, we're talking about women if they're taking a bike, which is the most often utilized mode of transportation, it would be with somebody. So they're not riding it on their own. And that's why we said, let's say just walk, because it's difficult to then differentiate and then just take up any trip in which they are doing any kind of walking, even if it's like till the bus stop. So that is why we thought that is the most appropriate in terms of measuring actually they're going out on their own, any kind of autonomy that they have. And that is why we also then looked into if they're walking alone. So then they have trips where they're going out, they say, oh, I went out with my sister or with my children or my husband. So we ask them, who are you going out with? So then they are saying, oh, we are going out alone. So again, just to bring out all that noise, we just focus on only the trips that where they say that we are going out alone. Just to, even though they would be like, okay, fine, and if all female trips would even be powered in Pakistan. So even though that would be interesting, we just didn't want, because we don't have lots of power there. We just have 2,000 observations. So that's why we just focusing on the unchaperoned or just low trips.
Thank you so much, Karina, for a very interesting paper and discussion. I would now like to call Salman to present the next paper. Thank you.
Punjab government in an immunization setting. So, the under 5 mortality rate in Pakistan was 81 in 2015, and that's third highest mortality burden. By 2020, it was improved, and Pakistan was then 22nd highest mortality burden. Not that great. In Pakistan, the immunization is handled by mostly the Family Program of Immunization by World Health Organization. There are and were some roadblocks in achieving or improving child immunization in Pakistan, predominantly parental awareness, education. There are in some areas influences of religious community leaders. Then there are logistical problems, and then the incentive for healthcare. So a little background. The childhood vaccination is between 0 to 24 months in Pakistan, and is carried through the Ministry of Health. And there are two common routes to receive this immunization. The first one is most healthcare facilities have the capacity to vaccinate children free of cost, and that, of course, we monitor. So parents have to take their children to the facility. The second, which is more common, is health worker vaccinators go to communities and offer these vaccinations. There are days when they go where they do door-to-door campaigns to carry out or communicate out. So that's a supply issue. So before 2015, these vaccinators were monitored based on their attendance register. So what used to happen was that they would, in the morning, they would check in at the local, at the central facility, get their vaccines, and go to their respective areas, their villages, or whatever they have been assigned to. And then, at the end of the day, they will come back, submit their register, and record how many vaccinations they have done that day. So, and the monitoring was done by the third independent surveys. So it's kind of a collective responsibility of vaccinators to keep their vaccination coverage of their area to be high. So there is a concern for free riding problem. In 2015, one of the 4 provinces of Pakistan, Punjab, designed an individual monitoring system and implemented it in late 2014, removing that free riding problem. So what happened after this intervention? Vaccinators are required to punch in and out through a GPS-enabled mobile device multiple times a day. So whenever they vaccinate a child, they will punch in and the GPS will record it, and then the district health management can track if the vaccinator actually went there or not. Later on, they also required to capture the photo of a children so that they can be sure that that children has been vaccinated. So this paper aims to draw causal estimates of this information. So we took the data from ESLM, and it has a section on immunization with a detailed record of immunization of children under 5, and we constructed 2 broad groups. Number 1 is ever vaccinated, which means if the children is in the health system or not. The second one is the vaccination coverage. So it's the percentage of shot administered based on the age of the child. Then we use the difference in difference with the birth year cohort as a treatment identification, and we'll also look at the heterogeneous treatment effects based on rural and urban areas, higher or low income groups. These are some summary statistics. So you can see the vaccination coverage is and everyone immunized was already high before treatment, and in control it was low. Okay, so when we look at the average immunized, we found a consistent estimate of 2.1% age point increase across different specifications. In the rural and urban areas, there is no difference between the treatment effect. However, due to this intervention. So we explore further. That's a pre-treatment trend and how it behaves after the treatment. There is a intervention implementation phase because we are taking the birth year cohort analysis. So if you look at the Q1 2014 line, children born at that time were subjected to treatment, but for a year, because by the time it's late 2014, they are already at 12 months. But the children who are born in Q4 2014 are the children who undergoes complete treatment. So in rural areas, we see no effects after the treatment, but in urban areas, we do find significant effects, and we also saw it in the analysis that it's 6.2% increase. When we explore it further and look at households that have low income, and I believe it's 50,000 PTR to consider to be a low income. So again, we see the effect of 10.2 percentage point increase in urban region with non-low income states. Similarly, when we look at the heterogeneous treatment effect based on education, we again see increase in coverage by 5.4 percentage points in urban areas whose household has at least one member with an education of high school or more. So what does that mean? So it means that this treatment has alleviated the health quality in Pakistan. So if I were to conclude, yes, the treatment does increase the average immunized children in Pakistan. They are at least in the system. But if you look at the vaccination coverage, all the effects is driving from educated families that are in urban areas and that are not low. So, in a way, the intervention fails to reach the most vulnerable population and aggravated the health inequality. Thank you.
Thank you so much, Salman.
Thank you, Salman, for this really important and interesting paper, especially in the context of Pakistan. As you mentioned, we've continued to struggle with high levels of child mortality. This imperfect vaccination coverage is not just important from the individual health perspective, but also from a public health perspective. And as I pointed out in the paper, that I think it is one of the first studies to look at a large-scale program in Pakistan and to evaluate its effectiveness. So I think it's really interesting and important in that aspect. Some of my comments, I think I've just sort of break them down into 2 or 3 main comments. Since you see most of your results concentrated in the urban areas, and the intervention in place was one that was targeted at improving vaccinator attendance and sort of improving the kind of records that are being held, vaccination records. I think it is important if the paper can add to how this intervention, if at all, is looking or encompassing urban areas. I say this because in my understanding, in urban areas, I'm not sure what the reliance on these supply-driven intervention mechanisms are, because children are being vaccinated at private clinics and hospitals. So it's important to understand how this intervention reached the urban areas, if at all, like I said. This wasn't in the presentation, but in the paper, because we also had a separate section on antigen doses, where we were looking at separate vaccinations. And you see most of the results coming from polio, so I think it becomes also important like that, because in urban areas, think here it would also be very interesting if you could do some heterogeneity analysis by the existing reach of the households to the health facilities. So for example, if you're using the PSLF data, I think there will be some data to suggest that if the mother used a hospital or a health facility for her maternal care, etc. And are we sort of looking at effects being concentrated just to those households that are already being covered by the health sector, or are we tapping into, are there any sort of additional margins there being exploited? And then I think lastly, again, if you could just add a bit more on the intervention and how it was also sort of linked with the underlying maybe health facility framework of the province. For example, if it was connected to, let's say, the basic health units in Punjab, etc., and if there is quite a variation in the quality of those BHUs, especially, let's say, in North and South Punjab, if, just broadly speaking. So are the districts within Punjab doing differently? So I think if you could just elaborate more on those points, then it will become easier to contextualize these results, the net effect or negative effect in the context of the rural setting, and the positive effect that we see in the urban setting.
These results are really interesting, and I guess my thoughts sort of echo the discussion, which is they could result from different configurations of consequences. In the abstract, you make an interesting claim at the end of the abstract, which is that the results arose from displacement of resources into urban and higher income areas away from rural areas. You didn't really talk about that so clearly in the presentation, and I'm curious about whether that's just a hypothesis or whether there's actually evidence on that. And really, more to the point that was raised in the discussion, if this was implemented effectively in low-income rural areas, might it actually show some impacts? Or is it that it just wouldn't work because there are other constraints that would hinder the impact?
Thank you. Very interesting finding. I was just wondering about mechanisms. So I was just thinking like two mechanisms. There is a discussion, I think, in the presentation. Since you're not actually evaluating the intervention itself, but you are taking the time and seeing pre and post kind of impact. So one mechanism could be if there is expansion of demand-side services, which Varda also was talking, in the urban areas, or more expansion of even private clinics in the urban areas than in the rural area, we would see the impact, which is not because of this policy, but because of that expansion. There is the chance of that expansion also because post NFC award, when provinces got bigger share of the budget and there is uptick in the health expenditures as well. The other mechanism that was coming in my mind is that, if the auditing or monitoring is through GPS coordinates, then maybe GPS coordinates are easy to get in urban areas than in rural areas. So the fear of being audited and monitored is higher in the urban area that might have triggered the impact. So people started to go and be investing in it, and they have no such fear maybe in the rural area. So this would be like the intensity of intervention.
This was really interesting. So I'm going to echo a lot of what Makar was saying. I was also thinking along the lines of mechanisms, and I thought again maybe monitoring, but then also as Makar was saying about the demand side, I'm wondering if you could look at maybe migration and see if that is driving the results as well. So are people migrating towards certain areas where you think there's going to be better healthcare, and that would be selective migration again. And the other thing is just a clarification. So I'm wondering why you didn't use mix, because that may have more information on the return on health and child healthcare otherwise as well. So was there a data limitation, or perhaps have you considered using it?
So now we open questions.
Thank you so much, Varda, for your valuable feedback and everyone. So, one of the things I think that multiple people is talking about here is the mechanism. Was also pointing out how this intervention affect urban areas. And Dr. Bukar also rightly mentioned that there is a fear of, because in rural areas there is no connection and they can make like excuses that it's be vended but it's not required. There are other mechanisms, but all of these are hypotheses. One of the mechanisms that I can think of is that the district management that handles the vaccination is also under the pressure of provincial government to administer more vaccines, and it's easier to reach to urban areas and administer more vaccines as compared to rural areas. So one mechanism that it did not affect the rural areas that much might be this one. So we have plans to study further and talk to the people vaccinators and the district health management further. Further, rightly pointed out that most of the results are coming from polio, and that's one of the things that concerns me. And it's not only coming from polio; it is they are coming from a decline rate of polio in other provinces. So it's like the polio rates decline in other provinces, but not in Punjab, giving us a positive effect. And our hypothesis is what Dr. Bukar mentioned about NFC ward. We also find out that the GIZ funding were also reduced uniformly across the provinces around that time. So we are trying to address that issue and somehow try to control these factors. One other thing that was mentioned was existing niche healthcare facility. That's a very interesting idea that I haven't think of. I will definitely try to get that as soon as possible. Yeah. Then Jonathan mentioned the displacement of resources. So the time when this intervention happened, there were lots of other interventions happening similar to technology, and there was like the PIT was the hero of that time, implementing lots of these digital interventions across different areas. So when we say that there is a displacement of resources from healthcare to these technological initiatives, it's not proven, but it's just our hypothesis that it's basically into that. Another thing that we talked in paper about displacement of resources is that because we could reach urban areas quite easily, this is also a case of displacement of resources that you can ignore rural areas for a while and complete your target from urban areas. Yeah, then Dr. Farah mentioned about migration. Again, it's a very interesting dimension to it, and I don't know how can we capture migration in BSLM or some other ways. I have to think about it.
There are, on PSLM and PHS, etc., you have, they ask a question of whether you are currently residing in the district of Bhubaneswar. So some proxies can be made.
Yeah. So yeah, I will definitely look into that. Regarding mix, at the time when I was doing, I was starting this paper, mix is not published that frequently as compared to PSLM. And my first choice was mix because it's more reliable as compared to PSLM and it has more detailed analysis. But it wasn't available that frequently. But things might have changed because if there is a newer version of mix. That's it. Thanks.
Thank you so much for a great discussion. We now are moving towards the third paper of the session, Cash Transfers and Postpartum Depression, Evidence from South South Africa. Personally, I'm really looking forward to this. So over to you, Vedra.
Good afternoon, everyone. So today I will be presenting joint work with Noah Loesch at Hamilton College and Jeff Bloom at IFPRI. It was sort of modified guise of this paper, and from postpartum depression right now is perinatal depression, cash transfers and perinatal depression evidence from South Africa. So really, what is the big question here? We're looking at if exposure to better economic conditions, higher income, is going to alleviate symptoms of depression among new mothers. And because now we're looking at the perinatal stage, this covers both pregnancy stage, that is the antenatal stage, as well as time soon after birth, which we refer to as postpartum. So we're combining the pregnancy stage and the postpartum stage and calling it the perinatal stage. So we explore relationship between perinatal exposure to this large cash transfer program and the mental health of mothers using this detailed panel data, that is the National Income Dynamics Study panel data collected in South Africa. It has over 5 waves and it started in 2008 and was collected up until 2017, so spans over 10 years. And we have a very nice age eligibility cutoff that we can take advantage of, which determines receipt to this cash transfer, this older person's grant. So as people turn 60, they become eligible for this grant, and that gives us a nice discontinuity that we take advantage of. So now the interesting thing here is that we're looking at exposure to a cash transfer which is not directly targeted at the mothers, but it is targeted to some elderly recipient in the household. And through that grant, the economic conditions of the household is argued to improve, which we show, and then that we argue is going to alleviate symptoms of depression among new mothers. So it's indirect exposure to the grant based on timing of pregnancy. And we see that this creates large effects and symptoms of depression among new mothers. So why do we care about perinatal depression? Basically, a lot of women suffer from depression during pregnancy and after pregnancy, and increasingly this is becoming an important topic. Mental health in development economics is becoming an important topic. So it's not only an end in of itself, like it's not only a goal in of itself that you should have better mental health, because if left untreated and unaddressed, it can be irreversible. But it is also going to have an impact on the other indicators down the line. A mother is usually the primary caregiver of her child, so if her mental health is not up to the mark, it can affect her parenting, and there are studies to show that it is going to have an impact on a child's health, on a child's cognitive skills, on their schooling outcomes, etc. So there are these two main reasons for why we should care about perinatal depression or just generally depression among during the vulnerable stages of pregnancy and after pregnancy, and we can find policies and ways to sort of alleviate it. Two main types of interventions have been studied in the literature. We've looked at cash transfers. There is some work on cash transfers, mostly conditional cash transfers, that are given to women during they're pregnant, and they're often sort of conditioned to them visiting hospitals for their mandated antenatal visits, postnatal visits, to have a birth in the hospital, etc. And then depression is basically studied as another outcome. So we have a bunch of those kind of studies. And then there are also some interventions that are sort of directly targeting mental health. These are the psychotherapy interventions where they kind of have sessions with the new mothers, and then they're going to basically track their mental health over time. But our intervention is different in that not only it's not directed directly to the mother, but it does not have any sort of direct bearing with what a mother does through pregnancy. So there are no conditionalities attached, etc. So we're just looking at the channel of how a large cash transfer, which effectively raises household income, can then produce these spillovers in the domain of mental health as well. So as I've already mentioned, what we do differently, it's again something that's indirect. We're also including pregnant women, and additionally the cash transfers and the psychotherapy interventions that have been studied in the literature, they only run for a very brief amount of time, right? They're basically short-lived. The cash transfers, the additional cash transfers are also going to last for a couple of months or years, and then they're going to basically, they're going to phase out. So we're looking at an old age grant program, which is basically a sustained, long-run, and large cash transfer amount. So it enables us to see those sustained effects as well. And then I think additionally, as far as your psychotherapy interventions and additional cash transfers are concerned, you could argue that there can be problems of sort of generalizing them or introducing them at scale, especially if you want large sort of segments of pregnant women to become your target group. So something like this, which is generalizable, is also important from a policy perspective. So as I've already mentioned, I'm using all 5 waves of the NIDS data that was first collected in 2008, and then these households were interviewed over a span of 10 years repeatedly. As far as the measure of depression is concerned, we use the CESD-10 scale. This is a composite measure of 10 emotions and feelings. So essentially, you're asking the respondent how they were feeling in the past 1 week, whether they were feeling bothered, whether they were feeling frustrated, annoyed, struggling, etc. And then they're supposed to rank how frequently were they feeling that emotion from 0 to 3. There are 2 positive emotions on the scale, that is, you are feeling happy and hopeful. So when the scale is constructed, it's just basically aggregating them. So the positive emotions scoring is reversed, such that a higher score means higher risk of depression. A cutoff of 10 has been used in the literature mostly to suggest higher risks of depression, but we show a robustness to other cutoffs as well, ranging from 8 to 12, depending on the different studies that are there in the literature. So this is one interesting motivation figure. What we see here is that women consistently have poorer mental health as measured by this CESD-10 score. And another relationship that pops out of this graph is that mental health improves in the higher wealth deciles. So as your economic situation improves, mental health improves. And then additionally, women are at a higher risk of depression, even at the higher levels of the wealth. Then we sort of just restrict to women pregnant, who are not currently pregnant, and then the time that has elapsed since childbirth to cover the postpartum stage. And you see that there is a spike when you sort of compare women who are not currently pregnant, but obviously have a baby at some point in time, but it's sort of something they have had a childbirth in the past. And then there is a spike in this depression score, suggesting that there is something happening when you are comparing this vulnerable stage of pregnancy and then right after childbirth. So as I've already mentioned, this old age pension or the older person's grant, the eligibility is tied to the age of the eldest member of the household. The eligibility begins at the age of 60, and it is a large cash transfer, which is about 140% of their median per capita income. And it is well studied. People have looked at the impact on spending patterns, on how labor supply changes in the household as a response to getting this grant, etc. And this is really the identification that we're taking advantage of. So as the elderly crosses the age of 60, the receipt, the share receiving grant, we see a jump. So this is the jump that we're going to exploit in our specification. This is for the overall sample, and we see a similar jump when we restrict to our sample of interest, that is pregnant women on mothers. Now, because we are, so this is, it looks like a standard RD, but we're using a variant of standard RD. We're using the local randomization approach. And so we're sort of dividing our sample into groups. Beta 1 is basically going to be measuring the impact on the CESD-10 score, which is the depression outcome. It's a binary indicator I show the main results, first I'd like to show the first stage results, that is to establish that this grant did have an impact on household income, and it was able to increase household income in the ballpark of around 16 to 20%. So getting this grant, so the first, this is basically a two-stage IA regression, where we are showing that if you're eligible, then you have over 50 to 60% chance of receiving the grant. It increases your probability of receiving that grant, which is that jump that I showed you in the plot. And then because of that grant received, your household income is actually increasing by 16 to 20% in different windows considered around the age cutoff. And now these are the main results, where as I mentioned, we're interested in the coefficient of beta 3, which is the interaction term between whether you're residing with an eligible elderly and whether you are a perinatal mother. And we see that it is consistently negative and it is also significant. So in the narrowest window, it's not significant enough to power issues, but as we sort of expand the bandwidth around the age of eligibility, we continue to see that the coefficient is stable and significant. What is the difference between the first and the second panel really is that when you're comparing new mothers with old mothers, the old mothers could have had a childbirth at any given point in time. So in order to make them more comparable to new mothers, we impose an upper limit of 5 years. That is, you would have not had a childbirth more than 5 years ago, and we see that our results stay consistent. Next thing, we also look at the heterogeneity of our results. We look at how these results are different in rural and urban settings, whether the oldest eligible beneficiary was a woman or a man, and what is happening if the overall environment of the household is depressed, if it is a low depression environment or a high depression environment. So we see that there's not much change as far as the rural or urban areas are concerned, but definitely it's more effective in male beneficiary households, and it's also more efficient in low depression environments, suggesting that if the household is undergoing a very particular type of vulnerability and stress situation, then this grant may not be as effective, but we continue to see a negative coefficient, although not significant. Again, we tested the robustness of our results not only to different windows that I've already shown you, a 1 year window around the cutoff 2, 3, 4, 5, but we also kind of changed the cutoff from 10 to 8 and 12. We see that our results hold, although not significant when we use 8 as the screening cutoff for regression. This is essentially the regression discontinuity plot. The main results that I've presented so far, while they sort of mimic that regression discontinuity framework, this is the actual RD regression and the result from that RD robust regression, and we see a dip in depression score as you sort of move to the right of the cutoff. One other thing that we did, as I've already mentioned, that the CESC-10 score was a composite of 10 different measures. So we also looked at all these measures separately. There were 8 negative emotions. For most, we see a negative effect, except for that I'm struggling and I need to put in a lot of emphasis and get things done. But as far as the hopeful and happy indicators are concerned, which are the positive emotions, we see the opposite effect as expected. So finally, we're looking to estimate the causal impact of perinatal exposure to cash transfers on the mental health of new mothers. We do see that this exposure results in a decrease in depressive symptoms, and it is coming through most of the measures getting affected as you would expect them to. The results are stronger for male beneficiary and low depression households. It is robust to different estimation approaches and definitions of the perinatal period. There could be some concerns that what if mothers are sort of strategically timing their pregnancies with, okay, someone is going to become eligible in our household, though we do not see any evidence of bunching around the cutoff. It's not that there is a spike in new mothers as the elderly becomes eligible. And the other thing is that we have the survey measure of depression. It's not a clinical or a medical measure of depression, and there can be underreporting, but it only sort of suggests that maybe that we're looking at sort of lower bounds of sort of detecting depression, and we may have to be a little careful in terms of the terminology we use and just call it maybe risk of depression or
Shweta Farina, over to you for your comments.
Thank you, Martha. This is a great presentation, great paper. I really enjoyed reading it. It was neat. The identification was strong, and I was happy to see because cash transfers are becoming more and more common. Pakistan is posting one of the largest cash transfers and their long term. So it's interesting to see what other indirect effects it could possibly have, and then we do not have enough data on mental health indicators. So that's interesting because and that's why we do not have lots of either. So, just to give a summary, the research question wanted to look at the indirect impact of unconditional cash transfers on the perimeter depression in women who are either pregnant or they have a newborn baby who is less than 6 months old. The methodology is regression discontinuity, and so I believe it is really important, as I said, one, the need identification strategy, but also having a 5 waves. It has lots of external value there. So some of the comments or clarifications. In terms of data, you're using mothers who have children of 6 months or younger, and you say that your results you are robust, but I think the results presented in the paper, they are not. So they become absolutely insignificant when we change it to mothers with 1 year or 2 year old children. So I'm not sure if what's happening there is maybe a strong justification of why this is the cutoff, because there is no relevance in terms of why you choose it. Is it because of the literature or anything other than this? So I think that is important because really if the results aren't holding for mothers with children, and if you see that graph that you showed, the depression kind of becomes constant. It doesn't change after your child is 6 months, more than 6 months old. So maybe it's just that depression, kind of becomes less adverse in those stages. So maybe some kind of justification to that. In terms of methodology, you did say that the age is the only eligible criteria, but then there wasn't 100% take-up. And in your paper, you also mentioned about the child support grant, which you did not mention if anybody who has a child is eligible for it. So if I have a child who is 6 months old, am I eligible or with it or not? Because if I am, then it would kind of hamper your causal identification strategy. So you would want to clearly differentiate between the two, and if you have data, basically that if the mothers are receiving child support grant or what is the cutoff age for that, then maybe you just want to put in there and show some robustness steps there. One of the things that I was thinking about when you did your heterogeneity analysis with female beneficiaries and male, again there isn't any clear explanation about, so what if both male and females are above 60? Do they both get? Is it double the amount of grant that you're receiving? Or is it just one person? And if it's one, then who do they decide whom to give? Is it the male or is it the female? Because we do have literature where we see that who gets the grant would affect the outcomes too, or how much it affects, or which outcomes does it affect. So what's the decision mechanism there in terms of who gets the grant? One thing which I did find lacking was that you did not see if the other variables, which could be possibly affecting the depression, are discontinuous at the cutoff or not. Because if they are, then it's probably they are. It's an indirect effect, not a direct effect. So maybe female glucose participation, or their health visits, or food consumption. Eldest child, I don't know if eldest child can possibly help you with your struggles of looking after children. So probably looking into those and see if they are, they are continuous or not. One last thing, and the rest are just minor. I don't know if your data allows, but is there a way to capture the relationship with the older household member? So is it your father-in-law or the mother-in-law? There is data which says that just living with parents-in-law increases postpartum depression. So is it something opposite happening? So So mechanisms is important to identify, if we could identify what the relationships are there. The rest are pretty much minor points, and we can check those later on. Thank you.
Thank you so much, Farina. Questions? Maybe?
Thank you so much. There are a couple of things that I was thinking about. One was, is it that it is just a very recent style of cash transfer that is then being directed towards helping the woman somehow that's leading to less postpartum depression? So I'm thinking that if you've been receiving this cash transfer for 10 years, would we see similar effects? Is it really what's being picked up? Is it a new experience and suddenly the household is feeling happier or spending? I don't know what they're spending on that's leading to less depression. I'm thinking it's overall a less stressful environment, and so maybe looking at what the stress levels look like of other people in the household might help you unpack what that mechanism is that Farina was alluding to. I think it's also surprising that it's coming through the male recipient, whether it's a father-in-law or your own father. What is really happening? So I'm thinking maybe it's less stress in the household overall. I think you should be able to unpack that with the data that you have. But also thinking a little about what is the theory of change here. Is it just that they've recently started receiving it, and hence they're happier overall, the stress is lower? And you could compare with people who've been receiving it for a longer time versus not just around another cutoff maybe and see whether you see similar effects.
Richard?
Thanks so much. It's a really, really interesting presentation. Yeah, I have a few questions. I was wondering if you are restricting your sample just to those who are means eligible for the old age grants. Yeah, obviously there's the age eligibility, but there's also an income threshold. And I'm not sure if I'm being right now if that will necessarily bias your results, but at the very least it might live lower than if you're including everyone. Potentially, if the structures are different between those who are and aren't eligible, which they probably are even at the composition of the household, it might introduce some bias. I also think the male beneficiary result is really interesting. It kind of stands in contrast to yesterday Flo's famous paper, Youth and Old Age Pension Grant, finding positive effect on girls only for female beneficiaries. So I think some discussion of that would be super interesting. Obviously, I haven't read the paper. And then I think also just lastly, I think the discussion also raised linking this a bit better to the child support grant literature, which is quite a lot in South Africa, would be really useful. In some senses, it's kind of the same. The child support grant, you're only eligible for when you give birth to a child, when you have a child. So, and you can be eligible for both at the same time. You can be receiving child support grant and the old age pension. So there's potential contamination, but I'm more interested in that the existing evidence of the child support grants finds very limited effects on depression for recipients of the child support grants. There are a few papers like Catherine Hale and Justine Burns in social science medicine and world development that find quite limited effects, some for people who are already depressed and limited intergenerational transmission as well. So I think linking better why your results are different would be interesting. It's also potentially attributed to a different sample. Females who are living with a grandparent or a mother or a father-in-law might be systematically different to all people who are pregnant or having. So thank you so much. That's super interesting.
Thanks, Farina. So, alright, so the child support grant, I think when we first started off, we started off with the duration of the year to define the postpartum period, and then, given the idea that, you all pointed out correctly, that there is another grant that households become eligible for after the birth of their child, which is the child support grant, and it's also sizable, and it is also an important grant in the context of South Africa. So we sort of shortened the duration of our postpartum period to 6 months. I do not have the graph here, but in the newer version, the version that we've been working on since, we basically show that it's really post 6 months where its child support grant receipt sort of exceeds 60%. So to avoid that issue of contamination, we were trying to really restrict our definition of parental period. You're right that when we expand, I think not with the 1 year duration, with 1 year duration, the results still hold and are significant, but as we go beyond 2 years and then 3 years, the results will reduce in size and then they lose their significance. For the means tested, again, like rightly pointed out, there is another eligibility criterion for getting this grant, the older person's grant, which is that there has to be some income restriction, there's means tested. But over 80% of the sample in our data are passing this eligibility requirement. So in the robustness checks, we do sort of, exclude the remaining 20% as well. But given that a very high percentage of our sample data points already qualify for that eligibility, the other eligibility, the means test eligibility, we sort of just run with the overall sample for the mean results. In my understanding, I don't think there is a limit to just one person getting the grant, and then as soon as you cross 60, I think you're eligible for the grant. So it would be interesting to see how it is if multiple people in the household are getting the grant, given that it is different for whether a woman or a man is eligible for the grant. I think in this setup, we sort of have some discussion with paper around it as to why it's kind of opposite to what we studied in the normal household economics literature, that if women are getting money, and we see an improvement in all these health and other outcomes, but we don't see it here. Which we, I think, argue is that if the woman is the oldest member in the household and is capturing a very certain type of vulnerability, maybe it's probably the widow or the older male member is not present, is sort of away from work, etc. And so it's kind of capturing a very sort of vulnerable section, maybe, which is why, and all those things are kind of countering, what a woman generally or normally would do with that cash transfer. And yes, so I think as far as, thank you for suggesting the bit on mechanisms, we are still working on mechanisms, and mechanisms is a bit sort of tricky in this context because mental health in of itself can be a mechanism for many things. Like even if we, like the old person's grant is set to improve sort of food consumption, it is set to alter labor supply, there are other papers, we can do similar analysis, but there's also that confounding bit that it could be your mental health first and then the resulting thing, so we're sort of trying to tackle that because it could be how you're feeling affecting how much you're eating, whether you're going to work or not, etc. So that direction is a bit unclear, which is why right now there is a bit of hand waving there, but we're yet to sort of work on that. I really like the point you talked about what is the relationship between eligible equity and definitely look at that. For how long has the person been getting the grant? What Penny pointed out, and that's also interesting. We can also look at that for sure. And yes, I think we sort of elaborate on the child support grant discussion paper. We've already sort of included that in the revised version, or we sort of make it more explicit. Thank you.
Thank you so much. I think we can give our speakers a hand. We can now go over and have a cup of tea and coffee to stay awake for another hour. So see you guys in 15 minutes. So please let's reconvene.